Thanks for the opportunity to give you a preview of these data from CheckMate-227. These are my disclosures. The standard of care for patients with newly diagnosed advanced non-small cell lung cancer has been platinum-based chemotherapy or pembrolizumab for those patients that have high PD-L1 expression. In a previous phase 1 study, CheckMate-12, we demonstrated that there was promising efficacy of a combination of nivolumab plus ipilimumab, and that there was optimized dosing when ipilimumab was given at reduced dose and frequency. In this initial study, activity of the combination was particularly enhanced in those patients that had PD-L1 expressing tumors. Since then, emerging data from a variety of studies have highlighted the potential role of tumor mutation burden as a biomarker that's strong and independent for the benefit particularly of nivolumab plus ipilimumab. In particular, an analysis of CheckMate-568, which will be presented later this morning as well, there was tissue was tested for Foundation 1, and there was a steady increase in response rate relative to an increase in mutation burden with a plateau around 10 mutations per megabase, which was then applied in CheckMate-227 as a pre-specified population in which to examine as a co-primary endpoint nivo plus ipi versus chemotherapy. Taking, I guess, one step backwards then to explore the trial design, CheckMate-227 was designed prior to the emerging data about tumor mutation burden as a biomarker, and instead focused solely on PD-L1. The design is shown here. Patients with treatment-naive advanced non-small cell lung cancer were screened for PD-L1 expression at entry and randomized based on PD-L1 expression. Those who were positive were randomized to nivo plus ipi or chemotherapy or nivo monotherapy. Those who were PD-L1 negative were randomized to nivo plus ipi versus nivo plus chemo or chemotherapy. Based on that initial data demonstrating that there was improved responsiveness based on PD-L1, the original co-primary endpoint of the study was to examine nivo plus ipi versus chemo in PD-L1 selected patients. This endpoint remains a part of the study and is ongoing. The results are expected later this year or early next. However, as we discussed, based on the emerging data about TMB as a biomarker, the study was amended prior to the initial analysis to include a second co-primary endpoint. Here we examined progression-free survival of nivo plus ipi versus chemotherapy in a predefined population of patients that were TMB high. The co-primary endpoint of the study is shown here. Progression-free survival was significantly improved with nivo plus ipi relative to chemotherapy in TMB high patients, with a hazard ratio of 0.58 and a p-value of 0.0002. The proportion of patients progression-free at 1 year with nivo plus ipi was more than tripled at 43% compared to just 13% with chemotherapy. There are two additional data points that I think help contextualize this result. The first is that we examined progression-free survival of nivo plus ipi relative to nivo monotherapy, particularly in a patient population that was PD-L1 positive. As a result of the study design, only patients that were PD-L1 positive received nivo monotherapy. And amongst this group of TMB high PD-L1 positive patients, there was still an improvement in progression-free survival of nivo plus ipi relative to PD-1 monotherapy. The hazard ratio of 0.75 is shown here, and the Kaplan-Meier curve that will be shown part of the full presentation show a clear stepwise improvement in progression-free survival at 1 year, starting from 16% with chemotherapy, up at 13% to 29% with nivo monotherapy, and up an additional 13% with nivo plus ipi up to 42%, highlighting a distinct contribution of the combination in TMB high patients. The second point is that we've demonstrated the value of the TMB biomarker and the effectiveness of the cut point. In clear contrast to the primary endpoint in TMB high patients, among those who were TMB low, there was no difference in progression-free survival of nivo plus ipi relative to chemo. The overall response rate to nivo plus ipi in patients with TMB high non-small cell lung cancer was 45% compared to 26.9% in patients with chemotherapy. And consistent with the transcendent durability of immunotherapy, the duration of response was also substantially increased. Again, nearly tripled with nivo plus ipi with a duration of response at 1 year of 68% compared to 25% with chemotherapy. Additionally, the depth of response was significantly improved in nivo plus ipi. 35% of patients had a halving of their tumors compared to just 12% with chemotherapy. There was also 9% of patients had more than 80% tumor shrinkage with nivo plus ipi compared to less than 1% with chemo. Understandably, there's been keen interest in whether there's an overall survival benefit. And so in order to help answer that question preliminarily, we performed an additional database lock in March. And I believe that this data is early, but still quite encouraging. The data here that's described is descriptive. And at this point, more than 50% of the data points are censored. Nearly all data points beyond 14 months are censored. And still, there's a clear trend in the improvement of survival with nivo plus ipi with a hazard ratio of 0.79. I think it's also important to note that the control arm here performed quite well with a median overall survival of 16 months with chemotherapy, and yet was still a full 7 months less than what was achieved with nivo plus ipi. Returning to the primary endpoint of progression-free survival, PFS was improved in most subgroups examined. This particular study enrolled all patients with non-small cell lung cancer, and there was a similar degree of benefit in progression-free survival of nivo plus ipi in both non-squamous and squamous histologies. And of particular importance, I think, nivo plus ipi significantly improved progression-free survival in both PD-L1 positive and PD-L1 negative patients, with a striking degree of similarity in both settings. This result highlights that TMB and PD-L1 are independent biomarkers, that TMB is predictive of benefit with nivo plus ipi irrespective of PD-L1, and that TMB high represents a distinct new subgroup of non-small cell lung cancer. Quantifying that population, of the more than 1,000 patients evaluated by Foundation 1 in this study, those that were TMB high represented 44% of patients with non-small cell lung cancer. And importantly, although the TMB analysis in CheckMate-227 was pre-specified prior to the initial analysis, the amendment to add this co-primary endpoint occurred after enrollment was completed, so sufficient tissue was not available for all patients, 58%. I think that point is probably explained in part by the small amount of tissue that was required as part of the study with just 10 slides, and some of that tissue was allocated for PD-L1 testing first. Not shown here, though, the baseline characteristics and outcomes of the TMB evaluable patients and the all randomized patients were nearly identical, highlighting the reliability of the results. And on the right here shows TMB relative to PD-L1 expression, showing no relationship, and again, emphasizing the independent nature of these biomarkers. In terms of safety, the regimen here, using a reduced dose of ipilimumab that appears optimized in non-small cell lung cancer, was well tolerated and similar to our previous experience in CheckMate-12. The rate of treatment-related death was just 1%. Perhaps most importantly in the context of immunotherapy, skin, endocrine, and GI toxicities were the more common of the any grade events, although each occurred in a minority of patients and were overall mild. The rate of grade 3 or 4 treatment-related, immune-related events were quite small. For example, grade 3 or 4 pneumonitis occurred in only 3% of patients. So in conclusions, in this study of TMB high non-small cell lung cancer, we found that nivolumab plus ipilimumab significantly improved progression-free survival compared to chemotherapy. The breadth, duration, and depth of response were all substantially improved, with more than tripling of the 1-year PFS with the immunotherapy combination. This benefit was independent of PD-L1 as well as histology. Overall survival is preliminary but encouraging, and nivo plus ipi with this reduced dose of ipilimumab was well tolerated. Overall, my sense is that this study has the opportunity to introduce 2 new options for patients with non-small cell lung cancer. The first is that the study demonstrates the clinical value of nivo plus ipi as a treatment option for patients with TMB high non-small cell lung cancer. The combination provided durable benefit, builds upon our progress in precision medicine thus far in lung cancer, spares the use of chemotherapy in the first-line setting, and allows a second-line effective option to be used if needed. And second, I think this study validates the role of tumor mutation burden as a biomarker and the effectiveness of the pre-specified endpoint to identify those who are at greatest benefit. This, I think, establishes TMB as a distinct and definable new subgroup of lung cancer and broadens the clinical actionability of data that we can derive from routine next-generation sequencing. Thank you.